Good afternoon, everyone. I'm Yusuf. I'm one of the fourth-year residents here at the Houston Methodist Vascular Surgery program. We have a very interesting topic ahead of us today, and that topic is going to be vascular surgery residents, specifically integrated vascular surgery residents going on to pursue a career in cardiac surgery, sort of fulfilling the goal of being true cardiovascular surgeons. Our program has actually had 2 residents last year match into cardiac surgery fellowship and 1 who's applying this year. And out of those 3, 2 of them will be joining us. We've got wonderful guests with us today. To my right is Dr. MacGillivray, who is the chief of our cardiac surgery department and our thoracic transplant department. To my left is Dr. Ross McFall, one of our 5th-year vascular integrated residents who's also applying to cardiac surgery. And joining us on Zoom, we have Dr. Marvin Atkins, one of our cardiac surgeons who initially was a vascular surgeon and then went back and did cardiac surgery fellowship after a number of years in practice, and Dr. Manny Rojo, who is one of our former graduates who actually graduated last year and is a first-year cardiac fellow at Loyola University School of Medicine. So thank you everyone for joining us. Just before we begin, we've got some instructions for everyone to submit poll questions as they come through. This is sort of going to be an open-ended conversation, and it's not going to be anything where we'll take questions throughout. You can join by web at pollev.com and you enter DEBAKEY in order to access the questions, or you can join by text by texting DEBAKEY to 37607, and you can text in your questions or your messages. Interview season is upon us. And so I know we've had previous interviewees ask us questions regarding why some of our vascular residents are going into cardiac, and actually last year why so many of our vascular residents are going into cardiac. So we'd be happy to answer those questions. We'll start, I believe we can start with Dr. Manny Rojo. If you want to talk a little bit about, you graduated from here last year, and you decided, I think you sort of decided last minute, if I remember correctly, that you wanted to do cardiac surgery. Is that correct?
Well, that's not entirely true, but I did graduate last year. So I'll tell you a little bit about my journey to where I am. So when I was in medical school, I was always fascinated by the cardiovascular system. That was always what got me most excited. And so I was, do I want to be a cardiologist? Do I want to be a vascular surgeon? Do I want to be a cardiac surgeon? And then very early on in medical school, I realized that I wanted to work with my hands and I wanted to do surgery. And so then it was between a vascular surgeon and a cardiac surgeon. And I remember when I came to that decision tree, I was always kind of bummed that the 2 weren't one specialty. I couldn't really understand how, why the diaphragm and the thoracic outlet separated the 2 specialties and they weren't the same, just because of those landmarks. But I had to make a decision, and I was between applying to integrated cardiac versus integrated vascular. And at the time, I think a lot of it had to do with my mentors. And there was also sort of this sky is falling sort of view going on around me of cardiac surgery, because there was the whole PCI movement, and everybody was saying, oh, stents, and CABG is going away. And so I think ultimately, though I seem to love both the same, I ended up going vascular because I felt like my mentors were sort of guiding me that way. And so I went into integrated vascular, but I never really lost that itch, that tug at my heart, no pun intended, for cardiac surgery. I always had that itch of, I want to do work on the heart, and I want to do work on the aorta inside the chest. And so it wasn't until I came to Methodist and trained there in vascular surgery that I realized that there's people that do both. Methodist, as you know, is a unique place where we have a lot of vascular surgeons that were trained by DEBAKEY and more of kind of the old school model where the cardiac surgeons did vascular surgery. A lot of our vascular surgeons help with the thoracoabdominals. A lot of our cardiac surgeons do carotids and bypasses and aortas. And so when I realized that it was possible to do both and to actually, do vascular surgery and do cardiac surgery, that's kind of when I started thinking about going into cardiac and applying to cardiac. And I was kind of torn between doing that and going into practice for a while. And yeah, last minute, I decided to go for it and go into cardiac surgery.
How about you, Ross? What was sort of your path into deciding integrated vascular and then cardiac surgery?
Right, so I studied engineering in college and I fell in love with the cardiovascular system. I think Dr. Lumsden has a show called Pumps and Pipes, and I just thought it was the pumps and pipes of the body. So I'd say that's where my interest started, and just like Manny, I had that dilemma where I was exposed to both cardiac and vascular surgery. I really wanted to go into both. I'd say I maybe keyed in a little bit earlier in my medical school that I could go down the integrated vascular route and then have the opportunity to go into cardiac surgery. And so that's what really got me into going into cardiac and vascular surgery.
And Dr. Atkins, so you took clearly a very different route than Ross and Manny here. You did vascular surgery, you were in practice for a number of years, and then decided to go to cardiac. What sort of drove that decision for you?
Yeah, so thanks for the question. So kind of complex. So I graduated medical school back in 2000, and at that time there really weren't opportunities for going directly into medical school into either cardiac or into vascular. And so it was just the traditional option of doing 5 years of general surgery. And so in general surgery, when I was in my fourth year applying to fellowships, I had applications for cardiac surgery, vascular surgery, and trauma, all kind of sitting in front of me, trying to decide what exactly I wanted to do. At that point, trauma was really moving towards kind of non-operative therapy for a lot of things, and so that really was a lot of ICU care, and that was less of what I was interested in, and so I kind of ruled that out. Between cardiac and vascular, most of my mentors at that time were really in the realm of vascular surgery. Thoracic stent grafts had just come out in 2005, were released in May 2005, the Gore tag graft. And so, not many cardiac surgeons were initially involved in that. It was more vascular driven. And so, at least in my program and our mentors, they were very much the vascular surgeons. Drug-eluting stents had just come out, and there was a real concern that coronary bypasses were going to go away. So this was kind of 2004. And so at that point, I kind of made the decision to go ahead and do vascular surgery. And so I was fortunate to match at the Mass General. I worked with Dr. MacGillivray there when we had combo cases, worked with Rich Cambria, mostly where we did a lot of thoracic aortic disease, a lot of open thoracoabdominals. And so a busy kind of thoracic aortic, central aortic practice. And so I brought that back to Texas, was in practice for about 9 years. And during that time period, I had a really busy practice. It was kind of actually a pretty sweet practice. I did mostly carotids, mostly aortic work, thoracic stent grafts, did not do any dialysis access, did not do any vein work. And you'd probably say, why are you crazy to leave something like that? But I had some issues where I was doing some aortic cases of where I was asked to come back after aortic dissections, type 1 dissections that had come in, that had gotten operations where they had just done a small ascending repair, didn't really debranch the patient, left the patient with kind of either an arch aneurysm or some problem that they wanted me to then kind of figure out from an endovascular standpoint to treat problems down the road. And I got stuck where I was having to, snorkel, brachiocephalic vessels, do a lot of things that weren't really FDA approved to treat these patients. And so I kind of made the conscious decision that, I had knew what people were doing across the country from an aortic standpoint, that we're really working together with our vascular surgeons, that we're setting these patients up for correct operations. And I kind of made the decision that if I'm going to, take care of these patients, I really need to go and punch my ticket to have pump skills to be able to, treat the entire thoracic aorta. So it took me about 3 years to talk my wife and kids to let me go back and do that, which was a lot of tough conversations and a lot of soul searching and a lot of promises. So it took a while, but ultimately was able to match at Penn and had a great 2 years there, was able to complete all of my training within 2 years, and not to have to do an extra aortic fellowship on top of that. And so fortunately was able to come back here to Methodist and do both.
Thank you for your answer. So, you know, what's funny is I applied to medical school wanting to do cardiac surgery, and it was mentorship that led me down the integrated vascular route. So it seems like the only reason anyone ever wants to do vascular is good mentorship. And then they ultimately go back to cardiac, which is funny. But Dr. MacGillivray, so as the pure, unadulterated cardiac surgeon in the room, we scrub with you during some of the complicated aortic cases. When we rotate on cardiac, I know our residents get to scrub with you. What are your thoughts on integrated residents versus general surgery residents coming into fellowship and doing cardiac surgery?
Well, I think it's great, and I think it only makes sense. If you look at the history of cardiovascular and cardiothoracic surgery, it's pretty interesting, and it just kind of evolved. I mean, thoracic surgery, and it's still, the board is thoracic surgery. It's not cardiac surgery or cardiothoracic surgery. It's thoracic surgery, and thoracic surgery was for many years a subspecialty of surgery. And certainly in the 30s and in the 40s, the focus was on managing infection, mostly tuberculosis or empyemas. And then that evolved into managing malignancies, lung cancer predominantly. And then heart surgery, dealing with mostly rheumatic heart disease. And that started back in the 1920s, and that kind of had I wouldn't say that really catapulted until maybe a few decades later. And then there's a real explosion in congenital heart disease, back in the 40s when the Blalock-Taussig shunt was done, and then in the 50s with use of cross circulation and the open surgical treatment of congenital heart disease. But again, it was all done by thoracic surgeons that evolved because of the fact that it all took place in the chest. And so that thoracic surgeons dealt with things in the chest, whether they were the heart, the aorta, the lungs, and the esophagus. And it was a subspecialty of surgery, so that the natural evolution for people who wanted to be thoracic surgeons was to train in surgery. And certainly when I was a resident and for the first 10 years I was in practice, you were required to have your boards in surgery before you could get your boards in thoracic surgery. But as we all know, that the specialty of surgery and the subspecialties of surgery have changed a lot. Like you said about cardiac surgery, and all of you said that there's this existential threat to whether or not it was going to continue to exist as a specialty. Well, it wasn't so long ago that vascular surgery was in that situation as well, and embracing endovascular treatment of vascular disease was really not just the renaissance, but the resurrection, I think, of vascular surgery as a specialty. And cardiac surgery is very much going in that direction as well, in that there are a lot of transcatheter solutions for what has traditionally been open cardiac surgical solutions for problems. And who best to go and train in cardiac surgery now than residents who have trained in endovascular and vascular surgery. I think that cardiac surgery and vascular surgery are moving closer together, and general surgery and cardiac surgery are moving further apart. One of the dilemmas that we have in the specialty, though, is that we continue to be, we're thoracic surgery. So there's adult cardiac surgery, there's congenital heart surgery, and there's thoracic surgery. So that, and it's one board, even though there are different pathways to getting board certified, the exam is the same. And so that even though the focus can be towards one of those three subspecialties, there needs to be training in all of them. And certainly general thoracic surgery is more similar to general surgery than vascular surgery is to thoracic surgery.
Is that something you see possibly changing in the future, or do you think things are moving in that direction?
What part of it?
As far as like, you know, thoracic just being something completely separate from cardiac surgery.
Well, that's a good question, and I don't really know the answer. People have talked about it. There really hasn't been much movement in that regard. Whether that's because of history or tradition, it's hard to know. I think probably that, you know, having it makes sense that vascular and cardiac surgery, and not just the surgeons, but I think that the management of the cardiovascular system, put, you know, imagers and cardiologists in that as well. I mean, I think that's how best that we're going to take care of patients with cardiovascular disease moving forward. Because I think surgeons are becoming more like interventionalists, and interventionalists are becoming more like surgeons. So I think that we're all sort of coming towards the middle.
Mm-hmm. Understood.
One thing I would add to that, Yusuf, would be in terms of, you know, is there ever going to be a time where there's a split between cardiac and thoracic? You know, a lot of smaller communities, they have a cardiothoracic surgeon that's there that takes care of both disease processes. There's probably not enough volume from a thoracic standpoint to, you know, have your own dedicated thoracic surgeon, your own dedicated cardiac surgeon. And so at least, you know, academic settings, you know, definitely there's, you know, two separate divisions in most places. But when it comes to community practice, you know, you're going to have somebody that can do both. And hospitals aren't going to hire two separate sets of surgeons, I would imagine.
That's a great point, Marvin. And most of the country are not big major metropolitan cities, and that to get people to travel 5 or 6 hours to go see a cardiac surgeon or a thoracic surgeon, at least the public doesn't really have an interest in doing that.
Yeah. It's a new paradigm will be cardiothoracic-vascular surgeons, it seems. So we do have a question from one of our viewers. I think Dr. Atkins and Dr. MacGillivray will probably be the best poised to answer this. What is the application slash marriage of both specialties outside of complex aortic work? Like, where do vascular and cardiac overlap outside of the aorta above the diaphragm?
Marvin?
Yeah, I mean, you know, obviously it comes back to the patient. So, you know, many of these patients are going to have concomitant disease processes. You know, very frequently we are referred patients that have coronary artery disease, surgical disease, and we'll examine them, we'll ultrasound them, we'll find that they've got carotid disease. We're more attuned to finding peripheral vascular disease, mesenteric occlusive disease. So, you know, many of these patients, it's the same disease process in different vascular beds. And who best to find those things than a you know, cardiac and vascular surgeon?
Yeah, I also think too, I mean, there's the field of structural heart disease, certainly transcatheter aortic valve replacement, TAVR. There are now more aortic valve replacements done with TAVR than with open surgery, and that's a big change over the last 10 years. Certainly going after diseases of the mitral valve and the tricuspid valve and the pulmonic valve are all within the reach and the realm of structural heart disease. The trap that's easy to fall into is to have patients treated by the door in the hospital they walk into. If they go to an interventionalist, they may get led down one treatment pathway. If they go to a surgeon, they may go down another path. And I think that's not, in my opinion, really the way we want to take care of patients. I think that we want to take advantage of the heart team or the cardiovascular team and get everybody together around the patient to look at really what is specifically the needs of the patient and how best can our therapies, taking advantage of each of the experts around the table, what are the best ways to take care of that patient, whether it's an endovascular solution, a structural heart solution, or an open surgical solution. And it's I would say that the toolbox isn't narrowing, it's broadening, and it's, and I think it will be more and more difficult as time goes on for every person at that table to be able to master every tool in that toolbox. And so I think we need to appropriately figure out, what is the best solution for each individual patient, and then get the people or the person who's best suited to do that.
So I know.
Also, from a structural heart standpoint, one thing I would say is that access when it comes to large bore sheath access, going through the aortoiliac system, going through the subclavians, going through the carotids. Nobody is better at exposing those vessels, fixing those vessels, realizing when there's significant plaque and narrowing or avoiding complications than somebody who's trained in vascular surgery as well.
So one of the things that I think one of the greatest challenges we have in thoracic surgical education is there is a lot of training that needs to take place in a 2 or 3 year period of time. And so one of the appeals for the specialty for cardiac surgery is being able to choose from a large group of very talented, trained vascular surgery residents who already have a tremendous experience in access and wire skills, and to then give them the benefit of open cardiac surgical training. If you have to take somebody from general surgery who doesn't have the same kind of experience that vascular surgery residents have, it's not that can't be done. It's just that you need to focus on more than you do for somebody who doesn't have those kinds of skills. Don't you think, Marvin?
Oh, for sure. Yeah, for sure.
Yeah, that's what I was going to say. I think that there's not so much procedural overlap. I think it's only going to increase as vascular surgery and cardiac surgery continue to combine, but also just the application of vascular surgery training in cardiac surgery, having the fine motor skills you develop in vascular surgery, performing a vascular anastomosis, as well as the catheter and wire skills that we're talking about. I think that's very important.
So both Dr. Sorry, go ahead.
Sorry, I was just going to add to that. There's a reason why it's called the cardiovascular system. Is that it is one system, and the two are connected, and you have to understand both. I think, or at least it really helps to understand both areas. For example, we just have a patient in the hospital now with mitral valve endocarditis who yesterday morning embolized to his left popliteal artery, and they called me in the morning and said, the patient can't move his foot, that he's in a lot of pain, we think he's having a stroke, and having that vascular skill to go and examine and say, no, he's not having a stroke, he can't move his foot because his foot's ischemic, and he embolized his popliteal, and having that is really, I think, crucial, especially when you're out in the community, where in the community you may not have a vascular surgeon and a cardiac surgeon in that same hospital, so you don't have the luxury of saying, call the vascular team to see this patient. That may not be the case, and so I think it goes, you know, far and beyond the aorta, and for vascular, you know, it's important to know, you know, if you have a patient with rest pain, for example, and they have left main disease, well, what does that mean? They have, you know, a really tight LAD, or they have an EF of 10%. Well, what does that mean to you? And I think if, you know, you have to understand that as a vascular surgeon when you're going to treat these patients. And so it's more than the technical aspects. It's also the patient management part of it that's really crucial, I think.
So I think so both Dr. Atkins and Dr. MacGillivray have so far mentioned that what sort of being a vascular surgery resident provides a benefit, or how it provides a benefit into going into cardiac training. But I want to hear from both Ross and Manny what you are, and Manny, you were an integrated vascular resident. What sort of steps did you have to take to prepare yourself and to make yourself an attractive candidate for a cardiac fellowship?
Well, I think, you know, they're just you're going to have weaknesses as a vascular applicant applying to thoracic surgery, and that's clear. And a lot of those weaknesses are going to come from your lack of exposure to general thoracic. So, for example, you know, I just started fellowship. I'm 3 months into fellowship. From day one of fellowship, I'm looked at as the thoracic fellow, and I'm expected to be proficient in EGD and bronchoscopy, and I'm not, and it's just the reality of it. I don't have enough experience in EGD. I don't have enough experience in bronchoscopy. You know, I'm going to figure it out, and but it's something that I have to catch up with, and so I think there is going to be naturally, when a vascular surgery resident applies to cardiac surgery or thoracic surgery, there's going to be that appeal of, oh, well, he already, you know, he can do anastomoses and he sort of understands the aorta and the cardiovascular system. But there's also going to be big weaknesses that programs are going to look at you and say, you know, you haven't done many EGDs, you haven't done a lung resection before, you haven't done those aspects. So I think if an integrated vascular surgery resident is looking to apply to thoracic surgery, they really have to be proactive about looking for rotations and building at least a basic foundation in the area of general thoracic. So you have to be able to do the basics in thoracic surgery. You have to understand esophageal cancer, you have to understand lung cancer, and I think those steps are crucial, because those will be your biggest weaknesses. And they will not realize when you show up to fellowship first day, they're going to think that you're, you know, like every other thoracic surgery fellow, and that you're proficient in these things.
So Ross, hearing Manny's answer, what have you done? And based off of Manny's answer, do you anticipate changing anything that you're already through the process, so you're already in, but is there anything that you wish you'd have done differently?
Well, I just finished a thoracic surgery month, and I'm really happy that I did that, because you know, when I stopped and I was thinking about the benefits and the advantages and disadvantages of this route. I think of a lot of advantages, but one large disadvantage is not having that general thoracic training like Manny's talking about. And so both Manny and Mujib and myself made a point to go and take extra time to rotate with thoracic surgery. But I think one of the biggest advantages that would make you a better candidate is, like we were talking about earlier, is mentorship and having early exposure to the cardiac team, and early conversation with Dr. MacGillivray and Dr. Atkins, and really getting plugged into that the cardiac side early. I don't know if it's a Methodist specific thing, but I think that was one of the biggest advantages of going down this route and making myself more of a stronger applicant.
So I think, a couple of the questions that are up there, I think the important point is that there is a lot to learn, and the expectation is that you will learn it all. And so if you go into a thoracic surgery residency thinking, well, I'm only interested in cardiac surgery and I don't really have that much interest in general thoracic surgery, or congenital heart surgery, you will literally fail, because you have to, the expectation is you're going to learn it all. And you have to, if you're smart, if you come from an integrated vascular surgery program, you need to catch up with the alimentary tract and the physiology of the alimentary and the hepatobiliary tract. You have to understand, endoscopy, and so you will already have a leg up on wire skills and access and vascular physiology and pathology. But you will be expected to know that. It's not just what you do, it's what you know, what you've learned to know that's very, very important, and especially because you have to, as I said, if you're going to be a cardiac surgeon or a cardiovascular surgeon or a general thoracic surgeon or a congenital surgeon, the board is exactly the same. The written exam is the same, the oral exam is the same. And if you can't pass it, you can't get your boards in it. So that's a very important message to be given from the very beginning.
At one point I was going to add is not just the cognitive stuff, just because, everybody's smart, everybody can read, everybody can catch up on all that stuff. But, one downside of this training paradigm would be the lack of laparoscopic and robotic skills that you would get during a general surgery residency. So especially on the thoracic side of things, where most operations these days are done either VATS or robotically, that is one thing that you would be behind compared to, say, a 05 general surgery resident that's done 5 years of either laparoscopic or robotic surgery. And so you do get a little bit behind with that, but again, you can catch up with most things. But there is a lot of stuff to learn. I mean, the boards for cardiothoracic surgery, I thought, were very comprehensive. And to catch up on congenital stuff, to catch up on all the thoracic stuff, especially where you may not, especially in a 2-year program like I was, you may have only had 1 or 2 esophageal perforations, and now you're expected to be the expert on it during your oral board for a very complex kind of situation. So, there's a lot of reading, and it's a brutal fellowship time-wise, and it's very tough to keep up with the reading. As I'm sure you're finding out, Manny, and you will find out soon, Ross.
Yeah, that being said, and a quick plug about our integrated vascular program, we're now officially a robotic vascular surgery program, so maybe we'll get more and more experience with the robot.
So, Dr. Atkins, how long ago did you complete your cardiac surgery fellowship?
So I finished in 2018.
Okay.
So I've been out doing cardiac for about 3 years now.
Okay, so 3 years in, what's the balance of your practice as someone who is board certified in vascular and cardiac surgery? I mean, I've personally scrubbed carotids with you, I've personally scrubbed bypasses with you, I've personally also scrubbed CABGs with you, but how do you find having both of those training paradigms under your belt has done for your career?
Yeah, so the good and the bad about it is that somebody who's trained and boarded in both of those specialties is going to be very busy very fast. So you are going to be the solution to all types of problems. One-stop shopping. Your referring docs will contact you, and you will be asked to take care of both sets of specialties problems on a daily basis. And so the good news is you'll get very busy very quickly. The bad news is that you'll get very busy very quickly, and it's hard sometimes to keep up with that. So my practice is probably about 70-30, maybe 60-40 cardiac, so it's a little bit more cardiac than vascular. It also kind of totally depends upon the practice situation that you're in. And so I practice part of the time down at Maine Methodist, I practice part of the time out at one of our peripheral hospitals. In our peripheral hospital, I have 2 other partners that are vascular surgeons, and so they do the vast majority of the vascular surgery work in our hospital, but I get also called on some of that stuff as well. And so, you're going to get very busy very quick. And at some point, you have to kind of carve out things that you either want to do or things that you don't want to do. And it just kind of depends upon the practice situation that you're in, whether you're able to do that or not.
Yeah, thank you for that. That's it's really interesting. I mean, like I said, when I was out there with you for that month, you'd get called for all types of things. And I mean, what you got from the ER was one thing, but your clinic was just all over the place as far as the type of pathophysiology you saw there. So everything from pop aneurysms to weird cardiac stuff that I had to look up in a textbook before I went to go see the patient. So it is interesting to hear sort of how you balance that. There's another question that came up there was that how are integrated vascular surgery residents viewed compared to general surgery residents? I mean, in my personal opinion, I would say it's probably an individual approach, and it's the individual resident, not necessarily their training, that makes their difference. What do you think about that?
I think that's right. I think that so when programs are looking to select residents, part of it is you want somebody who's going to be a good resident, somebody who's going to be a good addition to the training program, who's going to help take care of the patients and get the work done. And they also are looking for somebody who's going to add to the specialty, somebody who's going to contribute in a positive way, whether it's clinically, academically, educationally. And so, I think that whether you're, I think that probably like everybody, if when you interview with the cardiac surgeons, that they will probably have a kind of future resident they have in mind. When you interview with general thoracic surgeons, they will maybe have a little bit of a different bend in that. Maybe the congenital surgeon's third opinion. I think what you want to do is to impress upon the people that you interview with that you will work hard. You will, when you're doing your cardiac rotation, you'll be a really good cardiac resident. When you're on your thoracic rotation, you'll be a really good thoracic resident. And when you're on the congenital heart surgery rotation, you'll be a really good congenital resident. Mm-hmm. And I think that's what will carry the day.
So I wish Dr. Lumsden was here to answer this question also, but for both of you, Dr. Atkins and Dr. MacGillivray, within your professional societies, there's integrated cardiac surgery, there's integrated vascular surgery, and now there's a bunch of integrated vascular residents who also want to do cardiac fellowship. Is there talk about this? Is this something that people are discussing? Is this something that's come up?
It comes up a lot. That the future of any specialty has to do with the pipeline of the people who are going to train and take over the specialty and then train next generations. And so, as I mentioned earlier, there was when I was in training, there was only one way to get there. You had to do general surgery, and then you had to pass your boards, and then you did cardiothoracic surgery. Now you can do it that way. You can finish a general surgery training program and 5-year general surgery training program, and then go and do cardiothoracic. You can also now do an integrated vascular training program, and then go do a traditional track. There are 4-3 programs that you can do 4 years of general surgery and 3 years of cardiothoracic training. And then, of course, there's the integrated 6-year program for cardiothoracic surgery training. So there are a number of different roads that'll take you to the same place, depending upon how early you get interested or where you are when you get interested. Even like Marvin, I mean, you can delay it by 9 years if you want. I wouldn't recommend that.
Yeah, neither would I. So one thing else I would say from a kind of professional society standpoint is, there was a definite concerted effort, I guess probably in the 80s and 90s, of where cardiac surgery and vascular surgery split away from each other. So it used to be, the Southern Society for Vascular Surgery, the SVS, they were, some of the founding members of those were cardiac surgeons. And so, over the years, those two specialties separated away from each other, and now they're making some headway, especially with folks doing this training paradigm of coming back together. But I'm not sure everybody's drinking from the Kool-Aid just yet.
I think an important point there is time, because you look at all of those and they're all 7 years, right? Maybe 6, I6. And at the end of the day, with this training program, you come out with 2 board certifications. And I think it also puts you in an advantage to be on the leading edge of endovascular therapy as it becomes more and more prevalent in cardiac surgery. And so I think that's just an important point to look at when you're making this kind of decision.
How many other board-certified vascular and cardiac surgeons do you know, Dr. Atkins?
So I think we looked at this, I know there was a group that looked at this the last couple years, that there's probably about 30 or 40 in the U.S.
And out of that, how many of you have also kept your general surgery board certification?
So just out of arrogance, I actually, right before I did my general surgery, or before I did my cardiac surgery fellowship, I was up on my 10-year renewal for general surgery. So I did that test. So the recertification exams are much easier than the original exams. So I am triple board certified, but that has changed now such that most of them are getting away with a 10-year exam, and they're going to kind of a 2-year 40-question. So I just did the vascular surgery 2-year continuing education thing a couple weekends ago. So they're getting away from kind of a 10-year big test that you have to take time out of your practice and do a review course, especially if you haven't done it in forever. But I'm going to let my general surgery boards drop. I just don't do general surgery.
All right. Any other questions? Do you mind passing your mouse?
Sure. Well, I'd say, when I was a general surgery resident, I listened to Dr. Murray Brennan, who was the chief of surgical oncology at Memorial Sloan Kettering, and he gave what I thought was a great piece of advice for people who were training. And back then, laparoscopic, it tells you how old I am. Laparoscopic surgery and minimally invasive general surgery were just coming into their own, and there were fellowships in laparoscopic and minimally invasive surgery. And his advice was, don't focus on a technique, because techniques change. Spend most of your time trying to understand the diseases and the physiology and the pathophysiology of whatever specialty, whatever patient group you're interested in, and stay up on what the best way is to manage those patients as best you can. If it's open surgery, if it's laparoscopic surgery, if it's endovascular surgery, if it's using the robot, the person who's going to be best suited to take care of that patient is the person who still understands that disease the best and can manage that disease in the ways that there are available to do it. If you just focus on, if you became a lithotripsy surgeon for gallstones, you'd have a lot of free time on your hands. Because we don't really do that anymore. But that was back in, the 1980s. That seemed to be what was going to take over, gallbladder disease. But that, as you know, didn't really pan out very well. So focus on understanding the patients and understanding the disease processes.
Now that's a great point, Tom. I have a corollary to that story. In medical school, I had one of our general surgery program directors had a real interest in portal hypertension surgery, and so he had gone to the Emory Clinic, and I think he did a fellowship with Dean Warren of the Warren Shunt fame. And I think the year that he graduated, within a year or so, tips had come out with the interventional radiologists, and then basically that type of surgery is relegated to history for the most part.
Well, thank you very much, everyone who's both watching and participating. Before we close out, I wanted to sort of go in order of seniority, and just any advice for medical students or any residents who might be watching and have an interest in both cardiac and vascular surgery.
Am I the most senior?
Are you?
Manny.
Yeah. Wow. So I mean, I would say that when I graduated from medical school, I had no interest in being a heart surgeon, literally. I mean, I there's nothing about it that I found interesting or appealing, and I came to it in the middle of my general surgery training, and I think thoracic surgery, cardiothoracic surgery, cardiovascular surgery, there is no more interesting, exciting specialty than that. And for those people who think that the specialty is going away, I think it's bigger and better now than it's ever been. And it will, if you look at the leading causes of death in the country and in the world, it's cardiothoracic disease, and so there's a lot to do, and it's got a great, exciting future.
Thank you. Dr. Atkins?
I guess I'm next. So, I love my practice. I love being able to offer both sets of open and endovascular options to patients. If I had to do things over again, I would change the timing of things. I think it makes much more sense to do an integrated vascular surgery program first and then do cardiac than the converse. So, there are some people have talked about doing an I6 and then going back and doing endo skills. I think probably the way that you guys have thought about it and are doing it is probably the way to go. The one cautionary tale that I would kind of add out there is once you get out, you have to get a job. And that can somewhat be difficult depending upon what type of practice that you're interested in. So if you are, you want to go out into the community, you want to go into a medium to small size town, you are going to be highly sought after. CEOs of hospitals are going to be able to see that you can, with one hire, you can take care of 2 different sets of call schedules, 2 different sets of problems. You're going to get very busy very quick, and they only pay one salary, unfortunately. So from a community-based practice, it's the ideal treatment paradigm, training paradigm. When it comes to an academic practice, it becomes much more complicated. And what I mean by that is that in almost every academic center, you have cardiac surgeons and you have vascular surgeons, and most places have a separate thoracic surgery division as well. And so the question is, which cost center do you fall under? Who's your boss? Who do you, who helps you with your practice? Who's going to cover call for you? Who are your partners? And if those 2 different specialties are totally separated from each other, it becomes a little bit more complicated. And so, you kind of either have to pick one of those, and then you may not be able to do the other one's types of cases, depending upon referral patterns, depending upon privileging. And so it becomes, in an academic setting, it becomes a little bit more complicated for sure, but not impossible. I was fortunate to be able to find this practice where I can kind of do both things in an academic setting.
And Manny, as someone in your first year of cardiac fellowship?
For medical students, I would just encourage them that if they are interested in surgery and sort of are passionate and fall in love with the cardiovascular system, that this is, I can't think of a better training pathway. It's just having the vascular training really makes a lot of things in cardiac surgery make more sense, and it helps to really adds a lot to the training. And then I think being trained in cardiac surgery or thoracic surgery really adds to your vascular surgery background, and it makes you a better vascular surgeon if you've had that cardiac surgery experience, and it makes you a better cardiac surgeon, in my opinion, if you have that vascular experience. And I think the two specialties, unfortunately, a lot of times in a lot of institutions don't really talk to each other, but they really have a lot in common, and they really have a lot to sort of share with each other, and they enrich each other. So ultimately, I think the patients really benefit from institutions like Methodist, where the cardiac surgery department is one with the vascular surgery department, and there's really that communication between them. And a lot of these patients with very complex pathologies that would have otherwise been treated completely endo, or would have otherwise been given a large open operation, a lot of times end up with a hybrid of the two, and end up with sort of the best operation. And I think that the two specialties need to be more closely related in many institutions, and we have a lot to learn from the structure that sort of exists at Methodist, which is not the structure that exists throughout the country.
Manny, I have one more critical piece of advice for you. Being in Chicago, Astros won 10-1, so don't wear any of your Astros stuff out tonight.
He's got a lot of type A's coming in tonight. That's what I'm saying. I think there's a lot of advice. I think there's a lot of advice to give, but I think the main thing would be just figure out what you're passionate for and what your interests are early on if you can, and really stick to it, and don't let anyone tell you can't do what you want to do. Because I loved cardiovascular surgery back then, and I'm very excited to be headed to Boston to do additional training in cardiac surgery on top of my vascular, and I'm really looking forward to the future.
All right, well, thank you everyone for taking the time out of your day to join us. Hopefully for a lot of the medical students applying to our vascular surgery program this cycle, that helps answer some of the questions as to why a number of our residents actually go on to cardiac surgery. Not all of us do. I'm going to stay vascular, pure unadulterated vascular surgery. However, if you have any questions, feel free to reach out to our program. We'd be happy to answer them and put you in touch with the people that you need to speak to. So again, Ross, Manny, Dr. Atkins, Dr. MacGillivray, thank you for your time.
Thank you.
Much appreciated.
Thank you.
Thank you guys very much.